Welcome to the Deep Dive, the place where we take complex foundational texts and, well, we turn them into clinical shortcuts.
That's the goal.
Our mission today is really specific. We are plunging headfirst into the core concepts of female physiologic processes, and we're using Chapter 50 of Brunner and Suddett's textbook of medical surgical nursing as our guide.
Yep.
This isn't just about listing facts. It's about mapping out assessment pathways, management protocols, and really the absolute nursing priorities you need to know.
That's absolutely right. And think of this as a systematic navigation. We're covering the whole spectrum from basic anatomy and hormonal cycles, menarche all the way through menopause.
The whole lifespan.
The whole thing. And then we get into these critical, sometimes life-threatening issues like contraception, infertility, and crisis situations like an ectopic pregnancy. The idea is for you, the learner, to walk away not just knowledgeable, but clinically prepared, seeing it all through that nursing lens.
Okay, so let's unpack this right away with a couple of terms that are going to anchor our entire discussion. We need to be precise here.
For sure. Patients mix these up all the time.
Amenorrhea and dysmenorrhea, they sound similar, but they are completely different clinical experiences.
Exactly. We start with the basics. Amenorrhea is the complete absence of menstrual flow. This can be primary, meaning, the flow has never started, or it can be secondary, where it starts after it's already begun.
Okay, so A for absence.
Right. And then you have dysmenorrhea, which is painful menstruation. That's the crampy pelvic pain that so many women experience. So if a patient comes in, you immediately have to differentiate. Is it pain or is it a lack of flow?
And we're going to be talking about the internal structures a lot, specifically something called the adnexa.
The adnexa. Yeah, this refers specifically to the fallopian tubes and the ovaries. It's a collective term. And these structures are so often the site of acute pain or pathology.
Like cysts or
Ovarian cysts, or critically, an ectopic pregnancy. So when you hear a provider say they're palpating the adnexa, that's what they're doing. They're checking those specific almond-shaped organs and the tubes connected to them.
Got it. Okay, let's dive into part one. Before we even touch a physical structure, the textbook really stresses that women's health cannot be treated in a vacuum.
No, absolutely not. A nurse has to integrate this whole picture of physical, developmental, psychological, and sociocultural influences. It's all at play.
And that holistic view is paramount, right? It changes how you interact with the patient.
Completely. It tells you what barriers they might be facing. And there's this vital acknowledgement in the text that women are taking more responsibility for their own health care, but that interest, it often runs headlong into major structural obstacles.
Especially financial ones.
Especially financial.
And the Affordable Care Act, the ACA, it played a huge role in trying to mitigate some of that.
It did, yeah. The ACA expanded coverage through Medicaid, private insurance reforms, tax credits, all designed to make insurance more accessible. But the real-world impact?
Well, it's not a perfect fix.
Not at all. Despite all those efforts, women consistently report more cost-related barriers to care than men. It's just a persistent disparity.
So let's talk about the clinical impact of that. Who's most vulnerable, according to the text?
Well, even with the policy changes, you see these significant gaps. Women with low incomes, women of color, immigrant women, they're all still at a greater risk of being uninsured or underinsured.
And there's a specific statistic about single mothers that really stood out.
Yes. The starkest one cited is that single mothers face a 13% uninsured rate. That's significantly higher than the 10% rate for women in two-parent households.
A 13% uninsured rate. From a nursing perspective, that is a serious red flag.
It's a huge red flag.
If a woman is uninsured, she is so much more likely to delay screenings, avoid preventative care.
And only seek treatment when something becomes acute or, life-threatening. And that just turns preventative health right into crisis management.
Exactly. And this is why that second part of the ACA, the Mandate for Essential Health Benefits, or EHBs, is so critical for a nurse to understand.
Right. Because new private plans have to cover key preventive services without cost sharing. This isn't just some financial footnote. It's basically a blueprint for how you maximize preventative care.
So what are those specific services, the ones that are mandatory for the women we're caring for?
The list really defines modern preventative care. So you have Pap tests for cervical cancer screening, mammograms for breast cancer, bone density tests for osteoporosis risk, especially post-menopause.
And for reproductive and sexual health.
It mandates coverage for the HPV vaccine, all prescribed contraceptives, and even necessary breastfeeding supplies like high-quality pumps.
Wow. That inclusion of the HPV vaccine and contraceptives without cost sharing is That's a huge policy lever for reducing cancer and unintended pregnancies.
It's a game changer. And, don't miss the two other essential services included: screening for intimate partner violence, IPV, and annual well woman visits.
That IPV screening requirement, putting it right alongside physical tests, that really emphasizes how linked a woman's physical and psychological health are.
Absolutely. You can't screen for one without acknowledging the other. It means the nurse has a professional mandate, reinforced by policy, to ask about abuse.
Okay, let's shift focus to the physical structures.
Yeah.
Understanding the anatomy is it's the absolute foundation for a quality assessment. We can start with the external genitalia, collectively called the vulva.
Yeah, and we need to walk through this systematically. You have to know the location and function of each part. So starting at the front, anteriorly, you have the mons pubis. That's the thick pad of adipose tissue over the pubic bone. It's a cushion, essentially.
Okay, and then moving back from there.
Moving posteriorly, you find the two large, thick folds of tissue, the labia majora, which are covered with pubic hair. And then inside of those...
The labia minora, the two smaller hairless folds.
Correct. They join at the top to form the prepuce, which partially covers the clitoris. And the clitoris is this erectile organ. It's highly sensitive, and it secretes something called smegma.
Which is described as a pheromone.
A thick, sebaceous material, yeah. And then just below the clitoris is the urinary meatus, the urethral opening, and then the introitus, which is the vaginal opening itself.
And all of this external architecture, it really relies on internal support, doesn't it?
It does. The foundational support comes from this deep muscle layer called the levator ani muscle. It forms the pelvic diaphragm, and this muscle provides essential support for all the internal organs, and critically, it helps with continence.
So it helps a woman retain urine and stool when abdominal pressure goes up, like during a cough.
Exactly. A cough, a sneeze, lifting something heavy, it's crucial.
Okay, let's go internal. The vagina, the uterus, and the adnexa. What are the key features of the vagina?
The vagina is a muscular, highly vascular canal. It's about 7.5 to 10 centimeters long, and it's highly distensible, which is obviously necessary for childbirth.
Right.
The upper part of the vagina surrounds the cervix, and it forms this little recess called the fornix. And that area is clinically important because it's where samples of discharge can pool for diagnostic tests.
And the uterus is the central organ. What defines its structure and stability?
Well, it's pear-shaped, and its size changes dynamically depending on parity.
Meaning whether a woman has carried a pregnancy.
Right. A nulliparous woman, one who hasn't, generally has a smaller uterus than a multiparous woman, and it's held in place by this complex web of ligaments, like the round, broad, and uterosacral ligaments.
And the uterus itself has 4 parts.
Yes. The inferior cervix, that's the neck of the uterus, the superior rounded fundus, the main body called the corpus, and then the lower segment, the isthmus. But the uterine wall layers, that's where the real clinical action is.
Okay, break those down for us, especially the 2 inner ones, starting with the endometrium.
The inner lining is the endometrium. It's a highly vascular mucous membrane that thickens up every single cycle, preparing to receive a fertilized egg. If implantation fails, this is the layer that slips off during menstruation.
And the layer that gives it strength and contracts.
That's the middle thickest layer, the myometrium.
And this is where the textbook gives us that fantastic life-saving detail, the living ligature. I think we really need to expand on what that phrase means clinically.
Oh, it's such powerful terminology because it describes a life-saving anatomical feature. The middle layer of that myometrium has these interlaced muscle fibers, and they're arranged in this unique interlocking figure-8 pattern.
A figure 8.
Exactly. So when the uterus contracts forcefully, especially right after childbirth when the placenta is delivered, this figure-8 pattern acts like a living ligature. It mechanically constricts the blood vessels that were supplying the placenta.
So when the uterus contracts effectively, it literally ties off its own blood supply. It seals the vessels and prevents hemorrhage.
Precisely. And if the uterus doesn't contract effectively, a condition we call uterine atony, that living ligature fails and those vessels just continue to bleed profusely.
And that's the primary cause of postpartum hemorrhage.
The primary cause. It's a major obstetric crisis. Understanding that anatomical mechanism is absolutely paramount for anyone in postpartum care.
Okay, moving on to the adnexa.
Yeah.
The fallopian tubes and ovaries. Where does the magic of fertilization actually happen?
That typically happens in the ampulla, which is the widened part of the tube. The end of the tube, the infundibulum, has these tiny finger-like projections called fimbriae.
And they sort of sweep the egg in.
Their wave-like motion captures the egg released from the ovary and sweeps it right into the tube. And then the ovaries, those almond-shaped organs, they don't just produce the eggs, they produce the essential hormones, estrogens, and progesterone.
Which brings us to the menstrual cycle.
Yeah.
This complex process is governed by a really precise hormonal dance. We need to define the four key players clearly.
Okay, so you have the gonadotropins from the pituitary gland. First is FSH, or follicle-stimulating hormone. It stimulates the ovarian follicles and primarily estrogen secretion.
The other one is LH.
Right, LH or luteinizing hormone. It stimulates progesterone production, and most famously, it's the trigger for ovulation.
And then you have the ovarian hormones themselves.
Exactly. Estradiol, which is the most potent estrogen, it's responsible for secondary female characteristics and rebuilding that endometrium. And then there's progesterone, which is secreted by the structure left behind after the egg is released, the corpus luteum.
And its main job is to prepare the endometrium for implantation.
To condition it, exactly. So that 28-day cycle, which can vary widely, of course, is broken down by the changes in the endometrium.
So walk us through those phases, starting right after menstruation.
Okay, so we begin with the proliferative phase. FSH output increases, which stimulates estrogen. This hormone causes the endometrium to rapidly thicken and become more vascular. It's proliferating, it's getting ready.
And then around day 14, we hit the next phase.
Around day 14, we enter the secretory phase, which is also known as the luteal phase. And what defines that transition is the LH surge.
The big spike in luteinizing hormone.
This surge triggers the release of the egg that's ovulation. The corpus luteum is now active and it's secreting progesterone. So under this combined stimulation of high estrogen and progesterone, the endometrium reaches its peak thickness and secretory activity. It's a nutrient-rich bed, totally ready for a fertilized egg.
And if that egg isn't fertilized, the cycle continues to menstruation.
Correct. If there's no fertilization, the corpus luteum disintegrates, hormone levels just plummet sharply, and that top layer of the thick, congested endometrium is shed. That's your menstrual flow. And this whole complex sequence just repeats until a woman enters the menopausal transition.
The transition itself is called perimenopause, and it can start surprisingly early, can't it? Like around age 35.
As early as 35, it's characterized by these hormonal fluctuations and irregular cycles. And then the definitive menopause is the permanent cessation of menstruation, which is typically between 41 and 59 years of age.
And the physiological fallout from that dramatic decrease in estrogen is systemic. I mean, the textbook highlights age-related changes that touch nearly every system.
Every single one. And nurses have to be prepared to counsel women on all of them. The systemic effects include that vasomotor instability, the hot flashes, flushing, night sweat, sleep disturbances. But functionally, the loss of estrogen leads to accelerated bone loss,
Which puts women at a significantly increased risk for osteoporosis and fractures.
a huge risk.
And in the genitourinary tract, the changes all seem interconnected.
They are. Estrogen maintains the thickness and lubrication of the genital and urinary tracts. So when it decreases, you see decreased vaginal lubrication, and the tissue actually thins. We call that atrophy.
And that thinning leads to dyspareunia, or painful intercourse.
It does. And furthermore, the vaginal pH increases because the natural balance shifts. And that rise in pH directly increases a woman's susceptibility to urinary tract infections, UTIs.
That's a crucial link for patient education,
Okay.
connecting the thinning, the dryness, and that pH shift directly to an increased risk of UTIs.
Absolutely. And finally, decreased estrogen weakens the pelvic support structures. This can lead to pelvic relaxation disorders like a cystosol, where the bladder bulges into the anterior vaginal wall.
Or rectosol, the rectum bulging into the posterior wall.
Or even uterine prolapse, where the uterus itself descends. And these structural failures can cause pressure, discomfort, and a lot of difficulty with urination or defecation.
Okay, let's move into part 2, assessment and diagnostics. The comprehensive nursing assessment is really the critical first line of defense. What specific details must be collected in that health history?
You need granular detail. First, menstrual history. Age of onset, cycle length, flow amount, duration, any associated pain, dysmenorrhea, and any abnormal bleeding.
Like bleeding between cycles or any bleeding at all post-menopause.
Which is a huge red flag. Second, a full pregnancy history, including parity and past complications. Third, symptoms of vaginitis, urinary or bowel problems, and finally, a detailed sexual history.
The text also emphasizes integrating a genetic component, which I think is often missed.
It is, and it's vital for risk stratification. We have to identify family history for conditions like hereditary breast and ovarian cancer. But we also look for specific clues that might point to rarer syndromes.
Like what?
For instance, asking about the age when puberty was completed, Failure to complete it can signal conditions leading to infertility. And a really fascinating detail, inquiring about the absence of the sense of smell.
The sense of smell.
Yes. It's a sign of Kallman's syndrome, which is also linked to hypogonadism and infertility, so you have to ask.
Wow. Okay, let's focus on the sexual history. This requires immense sensitivity and skill. What's the goal here, and how do we use a framework like Placet?
The goal is not just to check a box. It's to get a complete, non-judgmental picture of the woman's sexual practices and satisfaction to promote her overall sexual health. And the key strategy is always rapport building. You move from less sensitive topics to more sensitive ones, and you must use non-assumptive language.
So instead of assuming heterosexuality or marital status, what do you ask?
You ask, are you currently in a meaningful relationship? Or, do you have a sexual partner, and if so, what is the gender of that partner? Using inclusive language just communicates safety and respect, which is foundational.
Okay, now Placet. Permission, limited information, specific suggestions, intensive therapy. How does this help a nurse structure an intervention?
It's like a safety ladder. You start by asking for permission. May I ask you some questions about your sexual health? If she says yes, you can provide limited information, maybe correcting a misconception. If she has a clear minor concern, you can offer specific suggestions, like recommending a lubricant.
And if the concern is more complex?
If it's deep-seated, related to trauma or identity, the nurse's role starts at referral for intensive therapy. It's a specialty service. It ensures the nurse intervenes only within their scope.
Okay, moving from history to critical safety issues. The source material is explicit about the nurse's responsibility to address intimate partner violence, IPV.
And the numbers are just horrific. About 1 in 4 women in the U.S. experiences IPV, which is defined by 4 types: physical, sexual, stalking, or psychological aggression. And the most critical piece of information we have to convey is that violence rarely stops or de-escalates. It usually gets worse over time.
So what are the absolute priority nursing strategies when IPV is suspected or disclosed?
First and foremost, patient safety and privacy are non-negotiable. You have to get her into a private room, door closed, make sure the abusive partner has left the room. Second, you must provide unwavering reassurance. You stress that she is not alone, that the abuse is the batterer's fault, and that violence is illegal.
And the documentation process here is unique, especially around confidentiality.
It is. You have to know your state's laws, particularly the difference between mandatory reporting for child abuse versus spousal abuse. And the documentation has to be detailed. Record her exact statements, and if possible, take photos of injuries, but only with her formal, written consent.
The ultimate intervention here is the safety plan.
It's the most practical step. You educate her that shelters are available even if she feels she can't leave right now. And you help her create a safety plan, an organized, rehearsed strategy for leaving. Where she'll go, what she needs, where to hide a packed bag, and important documents.
Okay, let's discuss another sensitive area. Female genital mutilation or cutting, FGM.
FGM is a human rights violation with severe health outcomes: chronic pain, infertility, serious childbirth complications. And nurses have to approach this with immense cultural competence. The text advises using the term cutting over mutilation, as it might be less inflammatory for the patient.
And for a pelvic exam specifically.
Critically, you have to carefully explain the function and purpose of the speculum. That instrument and the whole procedure could be unfamiliar or even terrifying given her history.
What about women with disabilities? Another often overlooked group that faces significant barriers.
They do. Studies show they get less primary and preventive screening care because of physical barriers, inaccessible exam tables, and just attitudinal barriers from providers. And the absolute non-negotiable rule in the text is this: a disability is never justification for omitting any part of the physical examination, including the pelvic exam.
So as a nurse, how do you overcome those barriers?
You prioritize communication, you address the woman directly, not her companion or caregiver, you ask about her self-care limitations, any sensory limits, and you specifically ask about accessibility issues with the equipment or the room. You have to adapt. It's an issue of equity.
And finally, ensuring sensitive care for the LGBTQ population.
This population is in every age and ethnic group, but they so frequently face insensitivity that it causes them to underuse healthcare services. And this leads to higher health risks: lower screening rates, higher incidence of cancer, heart disease, depression, substance abuse.
So what's the specific education a nurse needs to provide?
You have to use gender-neutral questions, appropriate terminology, and crucially, you have to cover STIs and HIV, even in populations that might assume they're not at risk. For example, recognizing that HPV and herpes can be transmitted via secretions and contact, including shared unclean sex toys, that's a vital education.
All right, now let's move to the physical assessment itself, specifically the pelvic exam. Proper preparation and technique are so key here.
Oh, absolutely. Positioning is critical. The most common is the supine lithotomy position. And the nurse has to explain every single step, emphasizing that the patient is in control. A great technique is to offer the woman a mirror so she can view her own anatomy during the exam.
And during that initial inspection, we're looking for signs of structural failure, right? Protrusions.
Yes, we ask the patient to bear down as if having a bowel movement. This increases intra-abdominal pressure and it'll reveal any weaknesses. We're looking for a cystosol, the bladder bulging forward, a rectosol, the rectum bulging, or uterine prolapse, the uterus descending.
And you also know the vaginal opening, which looks different depending on parity.
Right. It's usually round in nulliparous women, but often it's slit-like, or what they call fish mouth, in women who've delivered vaginally.
Okay, next is the speculum exam for visualization and screening.
The speculum has to be warmed and lubricated, ideally just with warm water, because some lubricants can interfere with pap testing. Then we inspect the cervix. A normal cervix is smooth and pink. We're looking for specific signs. Benign Nabothian cysts are common after childbirth, and the Chadwick sign,
The bluish coloration of the cervix.
an early sign of pregnancy. It's a vascular change.
And the pap smear is the primary screening tool here.
Correct. It screens for abnormal or precancerous cervical cells, and now it's almost always combined with HPV testing. And while that speculum is in place, you also assess any abnormal vaginal discharge.
Let's review the characteristics that differentiate the three main infections from the textbook's table.
This differentiation is key. For Candida or yeast, the discharge is typically thick, white, and curd-like, with a yeast-like odor. For bacterial vaginosis or BV, it's often a thinner, grayish-yellow discharge with a distinct fishy odor.
And trichomonas.
Trichomonas is noted for a copious, irritating, frothy, yellow-green discharge. You should be able to recognize those signs immediately.
After the speculum comes out, we move to bimanual palpation. This is where the internal organs are really assessed.
Right. This technique uses two hands, one internally in the vagina and the other externally on the abdomen, to assess the size, consistency, and mobility of the cervix, uterus, and adnexa. A normal cervix is firm. If it's softened, that suggests early pregnancy. If it's hard or immobile, that raises suspicion of a neoplasm.
And the sign of an acute pelvic infection.
The most dramatic finding here is the positive chandelier sign, or positive cervical motion tenderness, plus CMT.
The chandelier sign.
Yeah. It's severe pain that you elicit by gently moving the cervix side to side. It's named that because the pain is so intense, the patient might literally reach for the light fixture, the chandelier. It strongly indicates a pelvic infection like PID.
Wow. And how do you assess the uterus and adnexa?
The external hand presses down on the abdomen to push the uterus into the internal examining fingers, letting you check for size and contour. If it's fixed or immobile, that can suggest scarring from endometriosis or a malignant growth. When you palpate the adnexa, slight tenderness of the ovaries is normal, but you're specifically checking for masses.
Finally, the rectal vaginal exam.
This requires fresh gloves. Index finger in the vagina, middle finger in the rectum. This lets you assess the integrity of the posterior vaginal wall and can sometimes help you palpate deep masses. And you should reassure the patient that while the urge to defecate is common, it's highly unlikely to actually happen.
So abnormal pap smear results, they require immediate follow-up. What's the standard nursing protocol once those results are back?
The nurse often tracks and coordinates this. If the pap shows atypical cells but there's no high-risk HPV, the protocol is usually to repeat the test in a year. But if the results are repeat abnormal or if high-risk HPV is detected, then the patient needs the next level of investigation, colposcopy.
So colposcopy sounds like a specialized version of the speculum exam. What does it do, and how does that acetic acid work?
It uses a magnifying lens to visualize the cervix and vagina up close. The key step is applying a dilute acetic acid solution. The acid causes abnormal or precancerous tissue, which has a higher cell density, to temporarily turn stark white. We call this acetowhite tissue.
So it highlights the exact areas to biopsy.
Exactly. It guides the biopsy.
And if precancerous tissue is confirmed, you might move to a procedure like CLEEP. What are the major nursing teaching points post-op for a LEEP or a cone biopsy?
LEEP removes tissue for analysis and treatment, and the post-op instructions are critical to prevent infection and bleeding. The nurse has to stress this rule. Avoid intercourse and tampons for 2 weeks, or whatever period the provider specifies.
Because it introduces pathogens and can cause trauma.
Introduces pathogens to the open healing tissue and can cause infection or significant bleeding. And you have to tell them to expect a persistent watery discharge or spotting for several weeks.
And when irregular bleeding is the main complaint, what diagnostic procedure targets the uterine lining?
That would be the endometrial biopsy. It's a quick outpatient procedure to get tissue samples from the lining, especially for postmenopausal or irregular bleeding that makes you suspicious of cancer. The only real contraindication is a desired and confirmed viable pregnancy.
If you need a more comprehensive sample, then it's a DNC.
A dilation and curette, yeah. It involves dilating the cervix and using an instrument, the curette, to gently scrape the uterine lining. It can be diagnostic or therapeutic. But because it's more invasive, it usually requires anesthesia, and the same post-procedure teaching about avoiding vaginal penetration for 2 weeks applies.
Okay, let's talk visualization procedures, starting with laparoscopy. What's the unique procedural aspect that causes a common post-op complaint?
Laparoscopy involves inserting a scope through a small incision, usually near the umbilicus. And to see the organs, the surgeon has to perform insufflation. They inject carbon dioxide gas into the peritoneal cavity to lift the abdominal wall and intestines away from the organs.
And that causes the unique complication.
It does. Significant shoulder pain post-procedure.
So why does leftover CO2 cause shoulder pain?
That residual gas irritates the diaphragm, and because the diaphragm shares nerve pathways with the shoulder and neck area, the aphrenic nerve, the patient perceives it as referred pain in their shoulder. So you have to counsel them beforehand that this is normal, transient, and manageable.
And there's also hysteroscopy.
Right, that allows direct visualization of the uterine cavity itself inserted through the cervix. It's useful for evaluating pathology, finding retained IUDs, or performing therapeutic procedures like endometrial ablation, destroying the uterine lining for women with severe bleeding who want to avoid a hysterectomy.
And finally, 2 other vital things: hysterosalpingography, or HSG, and an absolute safety alert for MRI.
HSG is an X-ray where contrast material is injected through the cervix to check the patency of the fallopian tubes. For nursing prep, you need a bowel evacuation laxatives or an enema beforehand because gas shadows can mess up the image.
And the MRI safety alert. This is a life-or-death teaching point.
It is absolutely critical. MRI uses powerful magnets, and the nurse has to reiterate this safety rule. All metal devices, absolutely everything, must be removed before the MRI. This includes jewelry, piercings, and, critically, certain medication skin patches that have foil backing.
Because the foil can heat up and cause a burn.
A severe, full-thickness burn. It's a huge risk that can't be overlooked.
Okay, let's move into part 3, management of reproductive health in crises. We'll start with menstrual disorders and pain management. The text explicitly mentions the risk of toxic shock syndrome, TSS.
It's rare, but it's life-threatening. It's a staphylococcal infection, so nurses have to reinforce key teaching. Tampons must be changed every 4 to 8 hours, and women should always use the lowest absorbency necessary for their flow.
Okay, back to pain. Dysmenorrhea. We define primary versus secondary.
Right.
How do we manage primary dysmenorrhea effectively?
For primary dysmenorrhea, which is usually prostaglandin-driven, we focus on symptom control, reassurance, continuous low-level local heat, exercise. But the most effective pharmacological tool is NSAIDs, but timing is everything.
They have to be taken before the pain really starts.
Yes. In anticipation of the cramps, not after the pain has peaked. NSAIDs work by inhibiting prostaglandin production, so they work best before it causes severe contractions.
And if the pain is secondary, the focus just shifts to treating the underlying pathology.
Exactly. You treat the endometriosis, the fibroids, the PID, whatever it is.
Okay, let's talk PMS and PMDD.
Premenstrual syndrome, PMS, is that cluster of physical and emotional symptoms related to the luteal phase. Headache, bloating, irritability. PMDD, premenstrual dysphoric disorder, is the severe form where those symptoms are just debilitating.
What are the initial non-pharmacological strategies?
We start with charting symptoms over multiple cycles. It helps identify triggers, then lifestyle changes. Regular, vigorous exercise, stress reduction, sometimes dietary adjustments.
And this is where the nursing priority for safety hits hard. Managing severe PMDD. What's the protocol if there's a safety risk?
Well, pharmacologically, you can use SSRIs for mood symptoms or spironolactone for fluid retention. But in the case of severe PMDD, the nurse has to immediately assess for suicidal, uncontrollable, or violent behavior. Any suggestion of self-harm or violence requires an immediate psychiatric evaluation. This is an urgent referral, not just counseling.
Finally, abnormal bleeding definitions. Menorrhagia and metrorrhagia.
Menorrhagia is prolonged or excessively heavy flow at the time of the regular period. It can lead to things like iron deficiency anemia. Metrorrhagia is bleeding between regular periods. And clinically, metrorrhagia often warrants the most prompt investigation because it's a common early signal of serious problems, including cancer.
Okay, let's shift to contraception. This is foundational to reproductive health management.
For sure. About 43 million women are at risk for unintended pregnancies, so efficacy is paramount. And we measure that based on the number of unintended pregnancies per 100 women in the first year of typical use.
The text highlights LARC methods, long-acting reversible contraception, as the clear first-tier recommendation. Why is that?
Because LARC methods, implants, and IUDs, both hormonal and copper, are the most effective reversible options available, period. They have failure rates of less than 1%. They are as effective as female sterilization, but easily reversible.
So they eliminate that human factor of forgetting a pill.
Completely. They should be presented as the first-tier choice for women because of their reliability and ease of use.
Moving to hormonal contraception, the pill, patch, ring, what are the key non-contraceptive benefits and the major risks?
The benefits are significant. High effectiveness, reduced cramps and bleeding. They even offer protection against ovarian and uterine cancers. But the risks include side effects like breakthrough bleeding, nausea, or mood changes. And the most serious risk is a small increased chance of developing a venous thromboembolism, or VTE,
A blood clot,
stroke, or heart attack, especially if the patient is a smoker or over 35.
and the absolute safety alert that every nurse must repeat.
Hormonal contraceptives are highly effective against pregnancy, but they offer zero protection against STIs or HIV infection. You must always educate patients on using barrier methods, like condoms, to prevent transmission.
Let's talk specifically about the injectable progestin, Depo-Provera. What limits its use to 2 years?
It's highly effective and offers privacy, but continuous long-term use is associated with measurable bone mineral density loss. So because of this risk, the textbook advises limiting its use to 2 years unless no other method is suitable. So you have to assess the patient's risk for osteoporosis.
Okay, switching to barrier methods, focusing on the diaphragm.
Yeah.
What makes it so high maintenance?
Well, it has to be fitted by a clinician, you have to use it with spermicide, and it has to be inserted deeply to cover the cervix. And critically, it has to stay in place for at least 6 hours after coitus.
And the major allergy assessment needed for all barrier methods.
You absolutely have to assess for a latex allergy. So many of these products, condoms, diaphragms, cervical caps, are made of latex. Using them with an allergy can cause local irritation or severely anaphylaxis.
Finally, fertility awareness-based, or FAB, methods. Why do they carry such a high typical use failure rate?
FAB methods are safe, cost-free, and approved by various religious groups. But their reliance on monitoring cycles and abstinence during the fertile window leads to a typical use failure rate as high as 24 women out of 100 getting pregnant in the first year. It just requires extreme discipline.
And if a method fails, we move to emergency contraception, or EC.
EC is not for routine use. The options are EC pills, taken within 5 days, which mainly inhibit or delay ovulation. The most effective option is the copper IUD, inserted within 5 days. And the nurse's role here is providing supportive, non-judgmental counseling, and crucially, offering regular, highly effective contraception right after the EC is dispensed.
Let's move to managing pregnancy loss and termination. Spontaneous abortion or pregnancy loss is unfortunately common.
Very common. It occurs in 1 in 5 to 10 conceptions, often due to a chromosomal abnormality, and we classify them based on the clinical picture threatened, incomplete, complete.
Now, what's the general management protocol if the abortion is incomplete?
If it's incomplete, meaning not all the tissue has passed, you usually need intervention to prevent hemorrhage and infection. That might be a DNE, a DNC, or misoprostol to help the uterus expel the rest of the tissue. And the key nursing action is to save all tissue passed for examination.
Okay, now, induced abortion. What are the essential pre-procedure needs a nurse has to ensure are met? 3
non-negotiables. First, counseling to address fears and expectations. Second, lab studies, confirming the pregnancy, checking hematocrit, and most critically, determining the Rh factor. Third, if the patient is Rh negative, she absolutely must receive Rho-D immune globulin, RhoGAM.
Why is RhoGAM so vital in this context?
Because a pregnancy termination, spontaneous or induced, risks fetal blood cells entering the mother's circulation. If she's Rh negative and the fetus is Rh positive, this exposure can cause isoimmunization. Her body will form antibodies against future Rh positive pregnancies. RhoGAM prevents that.
What are the main methods of termination?
For early pregnancy, medical abortion is common, using drugs like mifepristone and misoprostol. Surgical methods include vacuum aspiration or a D&C.
And the final nursing role revolves around ethics and post-procedure care.
The nursing obligation is always to provide safe, comprehensive, patient-centered care. While a nurse has the legal right to refuse to participate in a procedure based on personal beliefs, they are professionally obligated not to impose their beliefs or judgments on the patient. And post-procedure, you must educate on what to report, fever, heavy bleeding, and provide immediate contraceptive counseling.
All right, let's talk about infertility and RT, Assisted Reproductive Technologies.
Infertility affects about 1 in 8 couples. It's defined as the inability to achieve pregnancy after 1 year of unprotected intercourse. And the evaluation is complex. You have to assess ovarian, tubal, and male factors all at the same time.
What are the initial diagnostics for assessing male fertility?
The standard is the semen analysis. You check volume, motility, morphology. The text notes a normal count is high, 60 to 100 million sperm per milliliter, but the likelihood of impregnation drops significantly below 15 million.
For women, if ovulation induction is necessary, what are the primary medications and what's the severe warning that comes with them?
Initial treatment often uses clomiphene to stimulate the ovaries. If that fails, you might use gonadotropins. And the serious warning associated with these induction drugs is the risk of ovarian hyperstimulation syndrome, OHSS.
Explain the mechanism and the clinical gravity of OHSS.
OHSS is a complication where the ovaries become greatly enlarged and multicystic from overstimulation. And crucially, it causes a dangerous fluid shift. Fluid moves from the blood vessels into the abdominal cavity, causing athites, pleural effusion, severe edema.
So this fluid loss results in hypovolemia.
Low blood volume, and hemoconcentration, which increases the risk of blood clots. So the nursing monitoring has to be meticulous. You're continuously monitoring vital signs, weight, abdominal girth, INO to detect early signs of a severe fluid shift.
Moving to aretates, what's the standard procedure?
The standard is in vitro fertilization, or IVF. Egg retrieval, fertilization outside the body, embryo transfer. Variations exist, like intracytoplasmic sperm injection, ICSI, where a single sperm is injected directly into the ovum. That's for severe male factor infertility.
The research profile in the text offers a really critical nursing insight into the psychological burden of these procedures.
It does. It's fascinating. The stress of infertility treatment is not equally distributed.
No. Research indicates that women consistently report higher stress and anxiety levels than their male partners, even after a successful IVF pregnancy is achieved.
So nursing interventions have to explicitly address this burden. Focus on stress reduction, counseling, and encouraging cessation of all forms of tobacco use, which significantly compromises RT success. And counseling should also compassionately include exploring alternatives like adoption or child-free living.
A final teaching point here, preconception wellness. What are the essential public health messages?
This is all about optimizing health before conception. Key points. Taking a daily multivitamin with folic acid to prevent neural tube defects, ensuring rubella immunity, avoiding all teratogens, and, crucially for patients with chronic conditions, achieving optimal glycemic control, especially if diabetic.
Okay, let's tackle our final crisis. Ectopic pregnancy. This is a full-blown crisis. It's the leading cause of first trimester pregnancy death.
It is. And the pathophysiology is that the fertilized ovum implants outside the uterus, most often in the fallopian tube. The causes often involve tube damage, previous pelvic infections, endometriosis, prior surgeries. Tobacco use is also a risk factor. The critical moment is tubal rupture, which leads to life-threatening internal hemorrhage.
So walk us through the clinical picture, especially the signs of rupture.
Initially, the patient might just report a delayed period or slight spotting, vague soreness. But with rupture, the pain becomes agonizing, followed by dizziness, faintness, nausea, and the rapid signs of hypovolemic shock, a rapid 30 pulse, decreased blood pressure, restlessness, pallor.
And the classic, highly specific sign is pain radiating to the shoulder and neck.
That referred pain is a vital diagnostic clue. It's due to the accumulating intraperitoneal blood. That blood irritates the underside of the diaphragm, and because of the phrenic nerve pathway, the brain interprets that diaphragmatic irritation as shoulder pain. It is a telltale sign of internal bleeding.
Diagnosis relies on serial HCG and imaging.
Yes. In a normal pregnancy, the beta-HCG hormone doubles every 3 days. In an ectopic, the increase is significantly less than normal. That immediately raises suspicion. Then a transvaginal ultrasound confirms the non-viable location.
Treatment options are surgery or, for stable cases, pharmacology.
If it's ruptured, it's emergency surgery. A salpinectomy, which is tube removal, or a salpinotomy, which is tube salvage. For small, unruptured, hemodynamically stable pregnancies, you can use methotrexate.
How does methotrexate work, and what's the required follow-up?
It's a powerful chemotherapeutic agent, a folic acid antagonist. It interferes with cell multiplication and DNA synthesis, effectively interrupting the rapidly growing pregnancy cells. And since it's destroying tissue, the nurse has to ensure a rigorous follow-up with serial HCG monitoring to confirm the pregnancy tissue has been completely absorbed.
Okay, let's define the nursing process priority for this crisis.
The absolute #1 assessment priority is the continuous monitoring of vital signs, level of consciousness, and the amount of vaginal bleeding to detect impending hemorrhage or hemorrhagic shock. Every 15 minutes, you should be checking for a falling BP and a rising thready pulse.
And beyond the physical, the emotional support is just paramount.
It is. The intervention focus is pain relief and physical monitoring, but you cannot ignore the profound grief and loss. And prevention is always key. The nurse must maintain a high index of suspicion for any woman of childbearing age reporting abnormal bleeding or discomfort, even if she claims to be using contraception.
All right, final topic. Menopause and hormonal therapy. Moving to the later life stage. The single most important rule here concerns postmenopausal bleeding.
Any bleeding 1 year after the cessation of menses must be investigated for malignancy. Is that right?
Absolutely. This is cancer until proven otherwise. The initial diagnostic step is a transvaginal ultrasound to measure the thickness of the endometrial lining. If a thick lining is detected, it warrants an endometrial biopsy or D&C.
Hormone therapy, or HT, is used to treat moderate to severe vasomotor symptoms. What is the current standard of care regarding duration and dose?
The paradigm has shifted completely. The clear recommendation now is that HT should be used at the lowest dose possible for the shortest time possible needed to manage those debilitating symptoms like hot flashes and night sweats. It's not generally recommended for long-term chronic disease prevention.
What are the absolute contraindications and key safety warnings that come with HT?
HT is contraindicated if the woman has a history of breast cancer, uterine cancer, impaired liver function, or any prior history of thrombosis. The risk of venous thromboembolism-DVT and PE is elevated while on HT.
So what specific signs must the nurse teach the patient to report immediately to manage that VTE risk?
They have to know the signs of a DVT unilateral leg redness, swelling or tenderness, and the signs of a pulmonary embolism, a PE, sudden chest pain, shortness of breath, unexplained anxiety. These are life-threatening and they must be reported immediately. And it's also important to counsel that HT does not reduce the risk of dementia, contrary to earlier beliefs.
And if a woman has contraindications or chooses to avoid HT, what are the non-hormonal alternatives?
Well, non-hormonal pharmacological options are available, like low-dose venlafaxine. Complementary therapies also show limited promise: yoga, meditation, some herbal supplements like black cohosh or soy, but the nurse must always inquire about and document the use of those supplements because they can interact with prescribed meds.
Finally, we need to end with health promotion for the aging woman.
This involves comprehensive education. Maintain bone health through calcium and vitamin D, combined with regular weight-bearing exercise. Prioritize cardiovascular health. And education should encourage the woman to maintain sexual activity, as it helps preserve vaginal elasticity. And finally, stress the importance of continuing yearly screenings, mammograms, colonoscopies, and well-woman visits throughout the aging process.
So, to synthesize the core nursing takeaways from this really intensive deep dive, competency requires a powerful synthesis of foundational anatomy-like understanding, that life-saving living ligature, with meticulous, rigorous safety protocols.
Right.
Nurses have to be vigilant in screening for abuse, for IPV, and constantly monitoring for signs of hemorrhagic shock, especially in crisis scenarios like an ectopic pregnancy. And this whole process has to be executed with unwavering cultural sensitivity and non-judgmental education, ensuring every single woman receives the holistic care she deserves.
We have provided you with the full clinical map. We've moved from those microscopic hormonal shifts that govern the cycle all the way through the challenging landscapes of assessment and diagnostics and into critical management strategies for crisis and chronic conditions. You are now truly armed with the foundational knowledge to provide competent, sensitive, and holistic care.
And here's a final provocative thought for you to consider. Given the high efficacy and convenience of LARC methods compared to the high failure rate of user-dependent contraception, and considering the policy mandates requiring access to preventive services, What ethical and practical responsibilities do healthcare systems have in ensuring that all effective contraceptive methods, especially those highly effective LARC devices, are not just available but are truly accessible as a default first-tier choice for every woman seeking family planning care, regardless of her socioeconomic or insurance status?
Food for thought. Thank you for joining us for this crucial deep dive. We'll see you next time.